Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett.
And I'm James O'Hara, nurse practitioner. Today we are talking about dementia. We've mentioned this on the podcast in the past, but we haven't really delved into sort of the diagnoses, the different roles that are played, different risk factors, and kind of all the studies that have failed. There is a lot of them.
Yeah.
I believe our last podcast was aimed at the monoclonal antibodies that got an FDA approval despite very limited efficacy. So we'll certainly touch on that again. Yep. But in other news, Mickey Mouse is now off patent.
Yeah. So this is pretty exciting because, as people know, as functional medicine and dementia healthcare providers, we base all of our practice on mouse and rat studies.
Actually, I think it's a good idea for our podcast. People realize that was a joke, I'm sure, but I think it's a good idea for our podcast to help people track along with the video. Anytime we mention a study, I think we're very good about mentioning if it's a in vitro study,
Correct.
if it's in mice, rats, or people. So any mouse or rat studies, maybe we can just have our editor quickly pop up the steamboat version of Mickey Mouse that we can use now and not get sued.
Yeah, so those are kind of our two favorite things. Talk about rats and mice and getting sued. And bears. So when Winnie the Pooh is off patent, that can be our secondary mascot.
That's a good plan. So to start off this conversation about dementia, we worked in a little bit of CrossFit here. How about those handstand push-ups? Better blood flow to the brain, right?
Yeah, so this is an intervention that could, it's exercise. It's a combination of aerobic exercise and resistance training, which is in some of these fancy protocols that you see, rightfully so. So I figured that the micro trauma from all the handstand push-ups I've been doing is going to cause some hormesis and decrease my risk of dementia.
Yeah, and two more punchlines on that. You can knock loose those amyloid beta plaques with headstand push-ups. It actually has the same risk profile as aducanumab does. There's a small risk of brain bleeding.
Yes, certainly a risk of brain bleed. It could certainly knock off a plaque, whether it's in your carotid or a different vessel. That being said, no exercise is without risk. So I don't want to live in a bubble room. But that being said, I would not do any of the floppy fish pull-ups or handstand push-ups if it were not specifically training for some sort of a competition. If only there was like an organization that didn't do those non-functional, non-helpful movements that don't build adequate strength.
Yeah, I wouldn't want to live in a bubble either, but that's where if I did do handstand push-ups, I would do those inside of the bubble.
Yeah, and then like an upside down handstand push-up where you have a barbell and you're pushing it up like that. It's basically a handstand push-up. But I guess we've digressed a bit. Another reason why we made this podcast is we saw a recent article posted by a well-respected neurologist, I believe.
Yeah, the two neurologists that are sort of in the preventive neurology space, at least in the mainstream traditional medicine. Isaacson, I believe, is the last name of one of the authors on that paper, and I think he was the first at Cornell to have a preventive program, and I believe there's a wait list to get in there. So they sort of posted a broad, overarching review of, what do we know, what do we not know? They highlighted a couple genetic factors.
Yep.
Lipids, talked about blood pressure, metabolic health, a lot of really good things in there.
Yeah.
But I guess to take a step back, we'll talk about kind of, what is dementia versus, mild cognitive impairment. So, we're coming from a hospital background. You see these ICD-10 codes, neurocognitive disorder, and you have like mild or you have major. So, mild cognitive impairment is where this person is still sort of functioning at their baseline level.
Yep.
They're able to complete their activities of daily living and pay bills. They may be sort of relying on, lists, reminders. They may be, having some obvious impairments, but they're still able to kind of manage and get by.
Yeah.
And a hallmark of both of these things is that it should not be caused by something else, right? So if you have a profound hypothyroid state, like that's an obvious case that is reversible.
Yep. Severe B12 deficiency. That's another reversible case. Along the continuum, I guess one way to explain this in layman's terms is you have normal function and then you have mild cognitive impairment, as you mentioned, also known as MCI. you could consider this pre-dementia, and then you have dementia itself. There's many types of dementia. So that's just kind of like, it's saying like heart disease. There's obviously ischemic heart disease, congestive heart disease, electric heart disease. With dementia, there's problems with dopaminergic function, like Parkinson's, Lewy body dementia. There's problems with cholinergic function and other things. With Alzheimer's, and with that, it's more characteristic with more amyloid plaques and tau tangles, although now it's kind of controversial whether or not those are just correlated or causatory of dementia. And then you also have other more rare causes of dementia, like prion diseases.
Yeah. So they have a list here of things that, there's different subtypes or things that are, known to be associated with it. Just like you mentioned, prion disease, HIV, traumatic brain injury.
CTE would be under that.
Yeah, exactly.
Chronic traumatic encephalopathy.
Yeah, any major insult to the brain, whether that's infectious or someone has had a vascular event, all those sorts of things are going to put more stress and causes an insult to the brain.
Yep. Huntington's disease is another rare cause. That would be another CAG repeat. Listeners of the channel know that we love talking about trinucleotide repeat diseases. Huntington's tends to expand over time. But that's kind of a general overarching view. We're mostly going to concentrate on Alzheimer's. You have early onset and late onset Alzheimer's. Yes, there's some disease states like Down syndrome where you're at risk of more early onset. And then if you're an ApoE4 heterozygote or homozygote, then it's higher risk of late onset Alzheimer's. And we'll kind of get into more of the details.
Yeah, I think that's a good overview. And I particularly like the sort of analogy you made with different subtypes of heart cardiovascular disease, sort of falling under that umbrella. There's different sort of vectors that are causative in dementia. So
I should have mentioned ischemic dementia. I don't know why I didn't mention that one. Plaque causing dementia.
Stroke kind of goes along with that.
And that.
Anyway, what do we have? About a dozen or so things here that we think are in the dementia prevention toolkit. First one here is diet.
Yeah, it's the first pillar of health. So like anything else, you are what you eat. Some, common causes of reversible dementia are nutrient deficiencies. So like anything else, when you come in with symptoms of cognitive impairment, hopefully the patient has come in before they have overt or obvious dementia. Sometimes that is the case. And they usually come in with family if that's the case. But ideally, you'll have a lab workup. You'll be looking at nutrient deficiencies, especially in a much older population. You look at serum nutrients and intracellular nutrients if possible. And then you're looking for specific genetic dietary requirements. Let's call this nutrigenomics. And arguably, these two would just be MTHFR and ApoE because they'd tell you basically how much do you have to watch your diet in order to improve your lipid status, and how much do you have to watch your diet to improve your methylation, B12, folate, homocysteine methionine status.
Yeah, so you can sort of take an objective look at someone's diet quality, but then the sort of surrogate endpoint you care about is, what is the blood work telling us? That's going to give you another layer of insight because not everyone is absorbing nutrients well. Especially think of the B vitamins with a decrease in production of intrinsic factors, people increase in age. Sublingual B12 looks particularly good. We may touch on that a little bit later. And then there's exercise. So this is, again, second pillar of health, something that's very important. And it's a part of really any dementia or any health condition prevention program. You want to have regular exercise. And sort of the bare minimum you look at there is, what the AHA and these different organizations have set forth. 150 minutes of moderate activity aerobic, and then a minimum of 2 times per week strength training. Both of those things are going to contribute to BDNF, which people talk about as like fertilizer for the brain and for outgrowth and connections of neurons.
But can't you just take a supplement for that?
You can.
Where's supplements on this toolkit list?
B12.
Well, that's under diet though.
Yeah, exercise in a pill is not here yet. And even with the mitochondrial uncouplers, I don't think that they'll fully be able to replicate that effect. I think you get that bit of hormesis from exercise, just like we talked about with the headstand push-ups. But yeah, you'll get certain aspects of the benefits. So they may have a pill for muscular hypertrophy. They may have a pill to increase your metabolic rate. But I don't think you'll be able to get one pills or even a combination of pills that's going to do the same thing that exercise does as a whole over decades.
Mm-hmm. I prefer my pills experimental, non-FDA approved, injected, and infrequent.
You're going to love bimagrumab.
That's probably will. That's the myostatin inhibitor, actin, a light chain actine, I believe.
Mm-hmm.
But anyway, next on the list is sleep. And again, not very sexy. This is the next pillar of health. So I guess if you're looking specifically for supplements along this, we'll talk about those later. But again, these are the most powerful interventions for health, more powerful than any pill, whether it's a medication or a supplement. They're the same. One's prescribed, one's not. They both have pharmacodynamic effects. They both have pharmacokinetic effects. I'll keep saying it because it's true, because some people are so anti-medication, some people are so anti-supplement. Some types of neurodegenerative disease are essentially a sleep disorder. Parkinson's disease is arguably the progression of a REM sleep disorder, and you're very likely to have REM sleep disorder of some type. So REM is rapid eye movement. In general, other than your eyes, your body should be paralyzed during REM sleep, but your brain is working. So if you have sleep paralysis, that's where your brain is not asleep. It's awake, but you're not moving. That's the opposite of REM sleep, where a lot of times in this like pre-Parkinsonian, pre-Lewy body dementia state, the substantia nigra, the dopaminergic neurons are dying. You are asleep, but your body's not as good at shutting down the movement. So you'll see the body moving around, and generally that shouldn't happen.
Yeah, I think that's a good way to look at it. And there's a lot of overlap with Parkinson's and dementia, both being neurodegenerative. And a lot of times they get lumped together as sort of the number 3 cause of mortality being neurodegenerative conditions, even though there's specific differences between the two. But next on the list, we have blood pressure. And arguably you could say that our sort of management guidelines are a little bit lagging behind what the data show. Kind of my rule of thumb is if you're 120 over 80 or below, about 3 out of 4 times you check your blood pressure, probably in a good range. Probably don't need to go on blood pressure medication.
Yep.
There can be exceptions there. Someone who has an existing cardiovascular disease, someone who should be on a beta blocker for one reason or another. But waiting until someone is consistently above 130 over 90, and then you tell that person, well, work on your diet, exercise, you come back in a year.
Eat more salt, do the vertical diet. Oh, wait, this is a serious podcast. This is not after hours. In all seriousness, blood pressure is particularly important. Think of the management of stroke. If there's any healthcare providers listening or people that have had a family member with stroke, is the blood pressure elevated a good thing acutely? Maybe in the management of stroke, but in the long run, you want to get that into tissue oxygen in the brain without needing to overload the blood pressure. So if you're watering a garden, you want the hose to not be clogged at the end. Otherwise, you're going to have to overload the pressure higher up in the hose. So think about what is causing the elevated blood pressure and what you can do to improve it. The average individual does not get enough magnesium or potassium in the diet. That's the theory, which is mostly correct, behind why some people can consume more electrolytes, slightly more potassium, slightly more magnesium, actually have improved blood pressure and perhaps improved kidney function. But again, you're thinking about hepatorenal syndrome, cardiorenal syndrome, and how systemic blood pressure is affected by those things. One other note on that, the gold standard for measuring blood pressure is actually ambulatory cuff monitoring. So basically a heart monitor every X number of minutes during the day and every X less number of minutes during the night. It goes off. They do this in Europe because it is much better for finding cases of things like nocturnal hypertension, which a lot of times goes with sleep apnea or nocturnal hypoxia. But they find more resistant cases of blood pressure. We don't really do that in the United States. We tried it in my residency. Everybody would just steal the blood pressure cuffs. So like you said, checking it several times at different periods of the day, that's when it's going to help. A lot of people do have white coat hypertension, but there is some people who just have stress hypertension, whether they're at the doctor or they're stressed at work or they're stressed at home. Their blood pressure is only elevated when they're stressed, but they're stressed 2/3 of the time.
Well, and I think the most common cause of white coat hypertension is actual hypertension. I saw a statistic, something like that. More than half of people with white coat hypertension have actual hypertension. Probably was validated with a 24-hour ambulatory monitoring like you're referring to.
Yeah. A very important takeaway here is if you don't want to have high blood pressure, or if you don't want to go on a blood pressure medicine, just say that and don't let it affect, don't gaslight your doctor. Gaslight your doctor into saying your blood pressure is normal every other time you check it with your calibrated cuff and at the pharmacy. So, don't worry about that pre-hypertension or hypertension code. If your blood pressure is elevated, then, be okay with that and do some shared decision making. Say, I don't want to take any medications. And there's lots of other things that you can do to control it, even in addition to the DASH diet that influencers hate these days.
Yeah, there was a recent study on that. But again, how feasible is it for someone to go on 500 milligrams of sodium long term? That was basically the dose they used to show that, I think it was 80% of people about their blood pressure did drop on that. But again, 500 milligrams is a low amount, especially for anyone who's exercising.
Yeah, that is a pretty low amount of salt. I probably put that much sodium. There's got to be more sodium in just like an element or I guess we should say a gorilla electrolyte.
Yeah, any of those are probably going to have close to a gram of sodium. Yep. So again, that's a tough one. But blood pressure, and again, going back to kind of the heart and the brain analogy, if you have uncontrolled blood pressure for years, that can lead to the development of congestive heart failure, which tends to have more overt, obvious signs. Like, you see your ankles start swelling up, or you lay down in your recliner and you can't breathe. Those things are going to be very obvious. Typically, these are going to be caught earlier. But if you do have someone who gets to late stage congestive heart failure, it's very similar to dementia in that they have, not great outcomes if you're looking sort of the next 5 years.
Yeah, that's why I donate blood every 2 weeks. It's always so thick after getting my hormone pellet. I figure if I do have high blood pressure, I just have so many red blood cells per volume of blood that I'm just going to have good oxygenation anyway. So I really don't need to worry about my blood pressure.
Yeah, if we put a pulse ox on you, it would probably be like 150%.
Probably. Next,
avoid head trauma. So, this, I think the best example of this has been sort of the awareness of the dangers of head injury, thinking about American football, sort of the attention that's been given to that in documentaries and different studies. This is true of really any sport or even occupation where you may encounter head trauma. Thinking of law enforcement or combat sports, football, even something like skiing is not without risk of head trauma. So basically avoid that. You don't basically use protective gear. If you're riding a bicycle, these things can, one, save your life in the short term, but also help protect your brain from the long-term effects of any trauma you might encounter.
Yeah. Our good friend, Diana Nguyen, sports dietitian, she talks about this a lot. She works with the military. She works with athletes. We've discussed DHA. We've discussed return to play protocols, and also how those might not always be perfect either, but they're a lot better than what's been done in the past. So see her page for more info on that.
Yeah, like if your quarterback gets their helmet shattered and then they just swap out the helmet and come back for the very next play without even a timeout. That's an interesting return to play protocol.
Yeah, it's only fine if it's Patrick Mahomes. He could never get injured. You just put too much money into him. So next is keeping arteries clear. So we've kind of talked about that. If you have a clogged artery, that can cause ischemic dementia. It can be big arteries. It can be small arteries. It can be embolic. It can be thrombotic. So it can be a stroke, or it can just be plaque buildup over time in small arteries.
Yep. So what's good for the heart is good for the brain once again. So managing risk factors, and this includes blood pressure, blood sugar, blood lipids, and also verifying that what you're doing is working. So we just had a whole podcast on this talking about lean mass hyperresponders and CCTAs clearly. So I don't think we need to rehash all of that here, but just verify that what you're doing is working because your brain or your heart may depend on it.
Yep. That's a good summary. Next is don't be diabetic. So you can't get type 3 diabetes if you don't have type 1 or 2 diabetes.
Yeah, and type 1 diabetes is often out of people's control. There's a heavy genetic component to that.
Yep.
It does run in families, but type 2 diabetes is almost always preventable. Like the vast majority of those cases, would not be happening with proper lifestyle interventions. Again, we don't have to go into sort of our environment and all the causes. We've talked about this sort of ad nauseum. But basically having the elevated glycemic excursions and elevated glucose levels is going to impair your blood vessels function, so the ability of the blood vessels to get blood to the brain. And you're also going to get a lot of extra oxidative stress that you don't need. And then you can get insulin resistance in the brain, and the brain is a very glucose greedy organ. It's going to use a lot of I think it's about 20% of your calories burned, or 20% of glucose is used by just the brain itself.
Yep. No, that's a good summary. And again, lots of discussion on this has been had in the past. This encompasses metabolic health. It encompasses metabolic treatments for mental health and cognitive function in general. So I think we've also discussed hyperbaric oxygen before and how that might be a better therapy. Like let's find almost a perfect candidate for hyperbaric oxygen. Not because they're a diver or they have burn injuries, but or gangrene, but a type 2 diabetic improved the type 2 diabetes and is now on a low carb diet. Everything's under control. You can pre-treat with some ketones and do hyperbaric oxygen therapy. That can be a pretty potent nootropic.
Yeah. There's a lot of good data showing, and again, these kind of cost prohibitive, but again, something that hopefully as more public interest and more people are using these things, that the, safety and affordability just gets better and better. Next on the list, and maybe we could have put this at number one because it's now the number one modifiable risk factor, is obesity. And if you are obese, you have a substantially elevated risk of getting dementia.
Yep.
Again, if you're obese, you also tend to have dysregulated lipid metabolism, elevated blood pressure, insulin resistance. Sort of all these things are intertwined, and it goes back to number 1 and 2, diet and exercise. So your calories in versus your calories out.
Yep.
And now more than ever, there are more ways that you can push back against obesity, regardless of whatever predisposition you have or whatever your state you're in today. Remaining obese is not a good way to push back and try to prevent dementia.
Yeah. And of course, there'll be a devil's advocate in the comments that say the highest risk for dementia is actually individuals in their 70s or 80s who are obese and then lose weight over the next decade, which has several potential mechanisms. But that shouldn't necessarily be the takeaway. The takeaway should be improved metabolic health. If you're losing a huge amount of weight in your late 70s or 80s, you're probably losing a lot of lean body mass. And that is also a huge negative. Our friend Gabby Lyon, she always says the skin is not the largest organ in the body. It's the muscle. So keep in mind that is going to drive your metabolic health, and that is going to be your, if you will, physical retirement account in older age that you are going to live off of.
Yeah, that's a good way to think about it. Next we have, again, I guess this overlaps a little bit with diet, avoiding excessive alcohol. So probably zero alcohol is the best. I mean, there's been the UK Biobank studies there. But the differences in like the endpoint of, let's say someone has 1 drink per month from age 30 onward. It'd be very hard to say, and the trial has never been done and never will be done. Does that actually increase the risk of dementia? So basically this comes down to, basically discussing, hey, what are the known risks? What are the known, benefits socially and staying connected to people? Those are definitely some of the confounders in the studies that show some positive effects with alcohol. Typically it's in a social setting. I mean, I can say there's probably zero benefit to drinking at home alone.
I would agree with that. And I have heard a lot of influencers say there's no benefit to alcohol whatsoever. And I understand it when they say that because they're all from California and they all do shrooms and weed there anyway. And that was a joke. Next is avoiding smoking. So, and you could put avoiding any potent vasoconstriction and any potent carcinogen in this category.
Yeah. And again, just thinks of like keeping pipes open, keeping blood flow going to the brain. carcinogens and tobacco smoke is mainly what we're thinking of. But
Mhm.
vaping is probably less bad, but still not something that I would say has a net brain benefit.
Mhm.
We may talk a little bit about nicotine later on by itself, but for right now, like avoid smoking. And these rates are actually something we've been very successful with in terms
Yep.
of a public health intervention.
Yeah. If you're looking to get a clip out of context of one of us talking, look later in the podcast when we talk about microdose nicotine. Next is maintaining social connections. Honestly, this could be near the top two for a multitude of reasons. What you do as a household, you tend to do together, whether it is quitting smoking, quitting alcohol, starting exercise, starting a diet, maintaining exercise, maintaining a diet, being happy, being sad.
Yeah, I mean, the social connections, I don't think you can sort of overstate that either, because now if you look at people who have hearing loss, there's been a handful of studies over the past few years looking at hearing loss and then the risk of cognitive decline, because these people are not interacting socially in the way that they were previously, and they may have a hard time understanding and carrying the conversation, and they may feel or actually be very excluded because so maybe people start treating them differently because it's like, well, they don't understand that they're hearing impaired. They think, well, grandpa's slowing down, that sort of thing. Next, we have cognitive challenge and cognitive reserve. So some of this you'll see with higher socioeconomic status and higher levels of educational attainment. Those people are thought to have put their brain through more stress up front and have more cognitive reserve. But anyone can start cognitive training of sorts. When we were preparing this podcast, we made the analogy of watching TV versus playing a video game.
Mm-hmm.
I mean, watching TV is a very passive activity. It's not particularly cognitively engaging, which is what most people do for, I think the last data was like 2 to 3 hours per day. People spend watching TV.
Yeah, way too much TV. It would be reasonable to completely get rid of a TV, especially now that everything is available on demand anyway. Because if you just flip on the TV, you're not going to be working your mind. So this is where you think about, well, what can you do? You can play Scrabble, or you can help your kids or grandkids or friends with projects, or they can help you with projects. Literally any hobby works for this. Gardening is one of them. You could do consulting work at your previous job. I know that my grandfather that has excellent cognitive function, even well into his 90s, he frequently goes by his place of work and, he does something there. And he's smart. Perhaps he helps from time to time. But, it just showing up, it gets you in that. It's so many times you see someone will retire and he or she will just decline so quickly cognitively after retiring.
Yeah, it's sort of a use it or lose it situation. And I think bringing up gardening is really interesting because sort of the avatar that I have in my mind when you think of an individual who's in their 80s or 90s or even 100s, and this person is doing really well, almost always I hear like, oh, yeah, they're still doing well. They still take care of their own garden.
Yep.
I don't know why that's such a common thing, but I think that directionally, if you looked at that population, that you would see, hey, yeah, gardening is a great activity. Maybe it has to do with some of the microbiome. That's a buzzword now. And if you're getting your hands in the soil and getting a bit more microbial diversity, but really, I think it's about sort of the cognitive and tending to something, and even the social engagement with people and their plants. Some people sing to their plants.
Yeah, you're making it. You have a map of your garden in your mind. It's probably great for hypertrophy of the hippocampus, just like being an Uber driver.
Without a GPS.
Yeah. When thinking about this list, I thought, what activities am I likely to be doing when I'm going through my centenarian decathlon? I'm getting through ages 80 through 100 or 110.
Headstand push-ups.
Probably not headstand push-ups, but probably a lot of walking and hiking. Again, hypertrophy of the hippocampus, making maps, going to new places. I know there's a study that's been done with trail walking on new trails versus the same route every day, and it's certainly helpful to go on new trails. Now, obviously, that comes with the risk of getting lost, but there's ways to minimize the risk of that happening as well. Other things that I would particularly enjoy: working at a museum, giving tours somewhere, that'd be fun. Volunteering at Department of Wildlife and Parks, teaching 4-H classes, teaching gardening classes, teaching anything about animals, at least in a safe way, volunteering at a faith-based organization or a local grassroots organization. Those are all helpful things that you can do that are arguably cheaper than buying some neural mind game that you just keep clicking on an iPad.
Yeah. And one more I would add to that would be preparing for podcasts. That's something that is very cognitively engaging, and I don't see myself ever not doing that in some capacity. So insert my own bias into this list here.
I thought you were going to say playing Call of Duty.
No, it's been too many years since I've done that.
Last on this list, that was kind of a little bit of a rabbit trail discussing the cognitive challenge, cognitive reserve, is depression and mental health in general.
Yep. So taking care of mental health is just as important as taking care of physical health. And now let's talk about HRT and dementia. So myself and Dr. Martin did a podcast on this recently, looking at a retrospective study that didn't tell us a whole lot of anything out of Europe. I think this was in Denmark where that study was done, and it was using their sort of oral combination, synthetic hormone products. But anytime those sort of studies happen, then the mainstream media picks it up and they just kind of get a tagline and they run with it. So the data on HRT in general is mixed. I guess really the only data we have on, the form of HRT that we tend to use, or that is tended to be used in average now in the United States, is the KEEPS trial, where they used a dose-targeted transdermal, or a serum level targeted transdermal estradiol system and oral micronized progesterone. There was also a oral conjugated equine estrogens branch in the study and a placebo branch. And there's an interesting graphic here that kind of shows some of the effects. Basically, if you're looking at HRT for cardiovascular protection, there's a lot of potentially better options out there.
Yep.
But if you look at, I think the most important thing out of this was the subgroup ApoE4 carriers and a lower deposition of beta amyloid plaques. We know that it doesn't necessarily prove that it is going to prevent or reverse dementia, but generally, if you could pick more or less, you would want to have less amyloid beta plaques. And we like to do things that are associated with better outcomes.
Yeah, pretty interesting, because one of the monoclonal antibodies that we've discussed before that targets beta amyloid plaque kind of after the fact, if you will, binding it up, is contraindicated if you have ApoE4 because it leads to too much edema and swelling. So I found that's kind of like an interesting corollary. I believe this is also one of the studies that discusses the correlation in white matter hyperintensity with FSHs. So the concern about like a particularly high FSH, as far as we know, is probably just correlation. But if you do have a particularly high FSH, then at least some sort of discussion should be had with your healthcare provider.
Yeah, and transdermal estradiol was better at suppressing that FSH compared to an oral estrogen product in this study.
Yep.
But we'll know more when the Lucinda trial is published. This is using leuprolide, every 12-week injection. Basically, we've got another year or so to wait for this to come out and see, is this actually having some sort of a positive effect or a neutral effect? Is it something that we can use because it's an older drug that, in theory, should be quite cost effective?
Yep.
But they may end up, having it rebranded and on patent and much more expensive at a microgram higher dose or something.
Yeah. Oddly enough, the company that makes this medication, I believe they also make one of the lymphatically absorbed testosterones that's also being studied for fatty liver disease. And there's certainly a lot of talk about, does TRT or does testosterone optimization prevent dementia? And the answer to that is, well, not really, but it certainly helps not to have low testosterone from what we know from correlation. We like the biobank studies, partly just because there's huge numbers behind them. You really can't take away a lot of the, even if you try to account for confounders, you're mostly just looking at correlation and not causation there. But it's interesting that low total testosterone and high SHBG are both correlated with dementia risk in males.
Yeah, because you think of high SHBG, being, manipulated by someone's metabolic health, but also you have less aromatization, less delivery of the testosterone to the tissue.
Yep.
So it's kind of an interesting paradox there. And you would rather have a normal testosterone level than a hypogonadal testosterone level, even if it's just being used as a tool so that you are able to exercise more and recover from said exercise. And one thing I'll add about the KEEP study that is kind of disappointing to me is that it is only a 4-year intervention trial. And then everyone was sort of, looks like they were pulled off of their HRT. They're still going to follow this group, but it's not answering the question about the duration of HRT and whether those benefits compound or stack onto each other if you look at someone who's treated for 4 years versus 10 years. So I really don't know if we'll ever get the answer there. It'll probably always be sort of a debated area and something you need to have a discussion with your care provider about.
Yeah, certainly interesting. Another interesting thing that might be looked at in the future is a combination of SERMs and SARMs. We'll discuss SERMs later. But again, thinking about suppressing FSH, maintaining metabolic health, and also attenuating cancer risk at the same time. Theoretically, there's not a perfect combination for everyone, but theoretically for each individual, there should theoretically be a perfect combination of a SERM and a SARM for each person. Because if you're thinking about the risks and benefits of hormone replacement therapy, usually the risks are in very specific tissues, like in glandular breast tissue or endometrial tissue or prostate tissue, to where those things can be modulated. So the future is exciting for that, but we are at least a decade or two away from that.
Yeah, precision SARMology.
Yeah, it'll be fun to talk about in the future. We also mentioned ApoE. That's a pretty well-known risk factor at this point. I believe this is the risk factor that that Netflix documentary was made about. And there's some misconceptions about this. It is a lipoprotein. If you have one of Thomas Dayspring's lipoprotein models, you'll see ApoE is one of the models on there, and you can have a couple different alleles, which is actually a combination of 2 SNPs.
Yeah, so we think most people ApoE3, that's about 70-75% of the population. You've got about a quarter of people that carry an E4, and very few people that have E4, just like very few people that have an E2, considered sort of a protective allele. There are some ethnic differences here. I don't know if we have all of those sort of in a file somewhere, but I know specifically E4 alleles don't seem to convey the same risk in an Indian population compared to Caucasians or Hispanics here in the United States. So we don't know everything about it yet, and it's probably a more substantial risk for women than it is for men. If you think of that average sort of 3 to 4x increased risk, maybe it's a 2x risk for men and more closely aligned with like a 4x risk for women who have that ApoE4 that they're carrying. Yeah,
and this is a lipid transport disorder. So if your protein that transports lipids, both cholesterol and triglycerides inside your lipoprotein, gets caught across the membrane, then you can either have not enough in the brain cell early in life or too much in the brain cell as well and lead to cellular dysfunction. So it can be particularly important to control your lipid status, not just LDL cholesterol, again, lipoprotein, but also triglycerides and specific types of cholesterol. I think we talk about those specific types later.
Yeah. 2 other genetic tests, the sort of second leading candidate there, and this is, again, not looking at like things that cause severe and early dementia. Those are sort of, more well parsed out, like I think P10 or PSIN, there's a couple of mutations there. And then SH-Moose was a newer one. And this was validated in 4 separate cohorts. It's a mitochondrial DNA, and I reached out to basically every commercial clinical company out there that is running genetic testing, and they have not incorporated this yet. You can comb through your whole genome, and you can see what that looks like. If you trust the company that sequenced that whole genome, you can see sort of if you have this or if you don't have this. But realistically, we're probably going to be waiting until a large, well-known clinical diagnostics company has a specific test for this. Yeah,
and this is mitochondrial. So there's other known mitochondrial risk factors for For dementia, people do get their mitochondria from their mothers. It is in the egg, not the sperm. So you would inherit this from your maternal lineage. It is protective. So if everybody on your mother's side has dementia, then maybe you didn't get a protective schmoose allele. But yeah, if your genome company does not look at mitochondrial genome, then they're probably not going to add this test anytime soon. It's something that we'd like to offer at some point in the future. We've come through genomes for some of our patients before, but like you said, the testing that is available to it is just
It's not perfect.
Not great. Probably
Yeah.
99%, which is not great accuracy for a clinical test.
Yeah, and we want to be optimizing mitochondrial function anyway, looking at some of the cofactors there. And then other protective, you hear about the FOXOs and things like, is it, Chronos or Clotho? Some of those, I think. But again, it's hard to know with some of these how protective exactly they are. I know there's I think the most data in Asian populations looking at the FOXOs and being protective and associated with longevity. But there's a bunch of different FOXO SNPs. So knowing which SNP is weighted, how much is very difficult to do. But we would think that if someone had every single protective FOXO SNP, they're probably going to be less susceptible to all sorts of diseases, including dementia.
Yep. Next, we can talk about desmosterol. So this is the kind of cholesterol precursor, one of them that we mentioned earlier. There is a lot of discussion and evidence regarding why it is important to look at desmosterol levels. But when you think about your cholesterol balance between absorption and synthesis, then this is a precursor to cholesterol synthesis. So if you're a hypersynthesizer, then perhaps you may run higher. And if you start something like ezetimibe, which inhibits the absorption, then that may secondarily upregulate cholesterol synthesis and thus desmosterol levels.
Yeah, and it's really interesting if you look at the reference range on the desmosterol in some of these labs, and then you have the individuals who are sort of fear-mongering about suppressing desmosterol, because higher desmosterol is labeled as worse on these labs. And there's perhaps some data there that desmosterol might be a proxy for your brain cholesterol synthesis, which your body sort of has two separate systems. Basically, all the cells are going to be producing their own cholesterol, from your Leydig cells that produce testosterone to your brain cells. The liver just is the primary target of drugs now, and even something like bempedoic acid is thought to be much more liver specific compared to statins.
Yeah.
But desmosterol, actually some interesting things out there. If you are on a combination of ezetimibe and simvastatin, which is a weaker statin, you actually have a higher desmosterol than you start from at baseline.
Mm-hmm.
Same thing with just ezetimibe by itself. That effect is even more pronounced.
Yep.
Other things that seem to improve cholesterol synthesis and clearance at the same time. DHA, short chain omega, omega fatty acid. And then there's also these correlations with higher desmosterol in people who would have impaired liver health. Mm-hmm. So you can't necessarily take it at face value. There's a lot of confounders there.
Yeah. So it's not worth giving yourself fatty liver disease just to increase your desmosterol levels.
That's a good takeaway.
That would be one reasonable takeaway. Another one would be, even if you get your desmosterol checked, at least the labs that we know about and the labs that we see checked, because we do see, which clinicians and scientists are ordering which labs around the health optimization community. They are normalized against total cholesterol. So I thought that, this is an interesting question. One, why do you want to normalize your desmosterol levels? Why wouldn't you just check, an absolute? Why does it need to be compared against your total cholesterol? If you're assessing synthetic potential, like how much of that cholesterol is coming via synthesis, via how much is coming from absorption, then that somewhat makes sense. But why wouldn't you look at it compared to non-HDL cholesterol? Is it because they want a larger effect size? Probably not. We found an interesting chart here that we'll include.
Yeah. I think, again, it's just sort of looking at, lumping people into synthesizers versus absorbers. I think that's like what the clinical utility is aimed at. And some people are sort of utilizing it as a marker of we've suppressed cholesterol too much, which theoretically, I suppose, if there's a mechanism there through statins, I think it's more likely through the mitochondrial effects versus, inhibiting something with brain cholesterol. But again, we'll probably have a whole separate podcast on this. We've already got some articles that we've dug into, and I look forward to that in the future.
Yep. Most desmosterol is in LDL cholesterol. So if you're looking at non-HDL cholesterol, there's a decent amount of VLDL, and most people don't have a ton of VLDL. But yeah, we'll do more deep dives in that in the future.
Yeah, for sure. And now we talk about marketing of reversal of dementia. So regardless of how you feel about the marketing there, largely dementia is not thought to be reversible. There are a few case studies in which there does appear to be improvement, but these are short term. So you're looking at, less than 2 years generally, and you don't know the duration of those effects. And it largely seems to be, looking at all the things people are sort of doing wrong in their lifestyle and then correcting that with a little bit of functional medicine sprinkled in.
Yeah. You want to have basically ensure your success by making sure that individuals improve their diet, their sleep, and their exercise. And then after that, you can add in your proprietary blend of supplements. And that's where you make your money, because you're not going to make money telling people to diet, exercise, and sleep.
Yeah, it's not catchy enough. And I would be interested to see in these studies, we can kind of go through what they are, but basically looking at these lifestyle interventions. So think diet, sleep, exercise, nutrients, looking at those things, homocysteine, which is, very evidence-based. And then seeing how much of the effect size is from those versus someone who's doing a toxin protocol for mold, or someone who is doing a Japanese knotweed, or someone who's taking an antiviral supplement and those sorts of things.
Yeah, it's hard for the layman or the average individual to parse out, do I need my anti-EBV antibodies checked? Or, do I need my heavy metals checked? Do I need to be checked for tick-borne illnesses? And occasionally you do. In fact, yesterday in our colleague group at Gillett Health, we were discussing, what are some, how can we get the best assay possible for testing this individual for tick-borne illnesses? We do live in Kansas, so it is not unheard of. And obviously it depends on where you live in the country. There's different tick-borne illnesses. We don't need to get into that, but that's just one example of someone sees a protocol, or someone sees someone they know, a friend or a family member that has done a certain protocol and paid a lot of money for it. And they're trying to figure out what percentage of that is the lifestyle interventions and what percentage of that is the herbal supplements or the chelation or the other supplements that they've bought. And it is likely about, depending on the person, 70 to 95% the lifestyle.
Yeah, I would say at least the lifestyle is doing the heavy lifting. It has the lion's share of the effect here. Some other things they added, ubiquinol. This is something that we recommend quite frequently.
Especially if you're on a statin, especially if you exercise a lot.
Yeah, and this is something that's actually very cheap to test in the blood. You don't need thousands of dollars of blood work to, get the bulk of this sort of a panel that they do in this recode protocol is what they call it.
Ubiquinol or CoQ10, it's something like $15 or $20 via Vibrant, and probably $40 via LabCorp.
Yeah, it's very affordable, and basically once you have your level and you've increased it if you need to do so, it's probably not going to change. Maybe you still check it occasionally, maybe on an every couple of year basis, just because as you increase in age, you may be sort of seeing that level decrease over time, 5 years, 10 years.
Homocysteine,
$12,
$15.
Same thing, very cheap test.
If it's under 10 and you have mid-normal B12 and folate or better, then you do not need to check an MTHFR polymorphism, unless it makes the clinic that you're going to money. Then check one. Obviously, that's a complete joke, but yeah, we are a fan of checking homocysteines, like you said, evidence-based. We discussed the homocysteine methionine cycle in the past. We discussed methylation, and B12 and folate status. You definitely want to improve those. Many individuals do benefit from a combination of either creatine, which does have evidence in individuals over the age of 55 for cognitive improvement, memory, object recall, I believe, specifically. Also taurine, which also helps in the cycle. Think of it as kind of like you don't need to work that methionine homocysteine cycle as much if you supplement taurine. Also, occasionally things like trimethylglycine, occasional things like L-methylfolate or methyl B12.
Yeah, it's very easy for most people to lower their homocysteine levels. One interesting sort of piece of data that we gathered over this past year is that there are lab errors that occur in homocysteine specifically. If the blood is basically sat there too long and it hasn't been run on the machine in the appropriate amount of time, you will see homocysteine levels very, very high. Yep. So this is what I think has happened in the case where some influencer, ex-influencer gets their homocysteine checked and say, oh, my level was 30 or 40 or 60. It probably wasn't. They should probably verify that very abnormal result. And maybe, in fact, it is high. We've seen them, I think, legitimately at levels of around 20 on the high end. But when someone says it was 60, again, I think that is probably a lab error.
That definitely needs follow-up.
Yeah, it definitely needs to be evaluated and managed if it is, in fact, real.
Over a level of something like 16, it also begins to be a risk of venous thromboembolism. So definitely talk to your healthcare provider about your homocysteine levels.
What about low-dose naltrexone? It seems like anyone with any history of an autoimmune disorder, they put on low-dose naltrexone in the RECODE protocol. This is open access, published. Anyone can go and look at this. So this seems kind of reasonable. Again, if someone had a history of, I guess I'm straw manning the case here, but if someone had a history of Hashimoto's and it was well controlled, they don't have evidence of damage, they don't have positive antibodies at this point in time.
How do you have Hashimoto's without evidence of chronic lymphocytic infiltration?
Maybe they had antibodies at one time.
It's like a little bit of heterogeneous appearance of the thyroid.
Labeled with Hashimoto's by again, it's a lot of times hard to tell where these diagnoses came from, whether this is from a functional clinic. Maybe they're diagnosed by a nutritionist, a dietitian, a chiropractor. Or maybe they were in fact
38.
Yeah. Maybe they were in fact diagnosed by an endocrinologist, and then they were on thyroid hormone for a short period of time and didn't have much damage to the thyroid.
Do they check an ANA to see who has autoimmune diseases? Because I believe over the age of 75 or 80, it's something like 80% of people have a positive ANA.
Yeah, it's not a very specific test.
Rheumatologists love referrals of 80-year-olds with mildly
low
positive
ANAs.
But yeah, in all seriousness, this is actually a reasonable thing. LDN does have some good evidence for various autoimmune diseases, including Crohn's disease. And you can kind of think of Crohn's disease and inflammatory bowel disease as somewhat like psoriasis of the gut, kind of. Not exactly. But you can look at inflammatory arthritis. Those are pretty similar conditions. So I can make a case that most people with inflammatory bowel disease like Crohn's or UC, and most people with an inflammatory arthritis, especially if they have a significantly elevated CRP, especially if they have dysregulated peristalsis, that LDN will not only theoretically help shift Th1 to Th2 immunity, it'll also help push things through with more normal peristalsis.
Yeah.
Important in older age.
Yeah, and it can be an adjunct as well for people who are on chronic pain medication, reduces the amount of opiates that need to be taken, sort of hitting the reset button on your sensitivity. I guess kind of going back to the published data, pretty unimpressive lab results that are published here. Probably the biggest change here is the HSCRP going from 2.2, which is still considered normal, down to just below 1. If that's a very positive change, that's something that you would like to see if you're looking at your own blood work.
That'd be hilarious if they gave them a flu shot 2 weeks before their pre-treatment CRP.
Just so that it's...
Flu shots and other shots can increase your CRP by about 1 to 2.
Yeah, just like any acute illness can.
And by the way, that's old school protocol to prevent dementia. Used to be getting flu shots, because if you get really severe influenzas, that in and of itself is a huge risk factor for dementia.
Yeah. So do Let us know what you think about that in the comments. That'll be an interesting one.
We'll leave it at that so we don't
Yeah.
get rabbit trailed. But
A1C dropped by 0.2%, so 5.4. I'm just rounding up. It's
definitely not from the exercise and diet
yeah,
changes.
it's a very normal number. And again, they were in a mildly ketogenic diet, so they're going to have pretty minimal glycemic excursions.
Yep. I'm glad they did not do a vegan or a carnivore diet, so props to them for that. That very reasonable whole food diet, essentially.
Yeah, homocysteine, and you would expect higher levels of this at baseline, but it was only about 10.5, and then they treated them to a level of 8.4. Vitamin D, these people were all vitamin D sufficient, which is interesting because if you look at the general population, most people are not. Most people at least have vitamin D insufficiency. But these people started around 41, 42, and they only increased by about 10 points over the study duration. So again, not a huge change. I don't think you would really move the needle much by increasing vitamin D. What's that, about 20%, something like that?
Yeah. That's a good summary. We mentioned several things that, were potentially actionable takeaways: the CoQ10 or ubiquinol, the inositol for some individuals. And a lot of people ask about omegas. In fact, we did just recently do a pretty big podcast on omegas. So thank you for any interaction on that one. But there's also been some, meta-analysis of various studies on omegas, and they're kind of all over the place.
Yeah, and things that I think are great about the RECODE protocol and the studies is that, hey, this does offer a glimmer of insight into what might be able to be optimized and reversed about things like dementia or mild cognitive impairment. What I don't like about it is sort of the monetization of a RECODE branded practitioner.
Yep.
Because these, based on my initial read, are not necessarily physicians or neurologists. This could be anyone that pays for a course. I mean, this could be someone who doesn't even have prescriptive authority. It could be a dietitian or a chiropractor, and then it's like, oh, well, according to the RECODE protocol, you need low-dose naltrexone, but that person is not going to be able to prescribe that for you because they're trained, but they don't have full. What am I thinking of? The full scope of practice that someone like a neurologist, a certified physician would.
It's like selling a protocol to rebuild a house. You're remodeling, you're revamping. The house is having dysfunction, and there's a builder, an excellent high quality builder that has a custom designed remodeling, and then it's selling prefabricated cookie cutter custom designed remodeling protocols,
selling the blueprints
to non-builders, non-professionals. So ask yourself if you would want that individual that is using that cookie cutter custom program to remodel your house.
Yeah, which people are still probably getting some insight if they're, putting, I don't know the cost of this, but I think I've seen 5 figures thrown around.
Yep.
If people are that invested, they're probably going to actually make these lifestyle changes.
It's an expensive way to have a better diet, exercise, and sleep.
Yeah. So mixed feelings from myself on that. Some things we might potentially add to this. So Shilajit, I'm going to put on my Mickey Mouse hat here because in the mouse data, Shilajit, which I kind of think of as an extra layer of like a multivitamin, maybe more specifically like a multivitamin, multimineral for your brain.
Fulvic acid.
Yeah, fulvic acid, preferably a sort of trademarked or extract that's actually been standardized and studied.
Or you can scrape it off the side of the Andes or Himalayan mountains yourself.
Do it yourself,
like the Sherpas do.
If you live in the right area.
Yep.
But it inhibits the formation of these tau tangles in the mice data. And there's one study that supports an improvement in testosterone level, but it wouldn't be my first go-to if I was looking at someone trying to optimize testosterone. Diet and exercise are going to be much larger levers to pull.
Yeah. So again, not really any outcomes data. You love the term outcomes data. I know that. But from a standpoint of you're thinking about like less tau tangles, less NFTs. I had one of my friends who does like cryptos and investments say the less NFTs, the better. So that's what I figure is true with Shilajit. Next is controlling your lipids. So this could mean a variety of different things. I did find it interesting that they touched base on lipophilic and non-lipophilic statins. And that's something that we could really talk about for quite some time.
Yeah. So, there is a small number of people who get side effects from lipid-lowering medications. Most people would stand to benefit, and that's consistent with the meta-analyses and randomized controlled trial data looking at dementia or cognitive impairment as an outcome. When someone, like maybe a particular astronaut, takes a statin and says that it gave them cognitive impairment, that probably is the case. I don't think they have anything to gain from making that up other than lots of book sales. But realistically, it is possible that that happens to people. We know that there are unexplained drug reactions, unexplained supplement reactions, and we don't want to completely discredit or gaslight our patients, even if they may be gaslighting us about their blood pressure.
Yeah, that's certainly true. One thing to keep in mind about this is, and I brought this up in the podcast before, is you have those patients and they say, you know what, I just don't want unnatural medications unless it's TRT, which increases your HMG-CoA reductase enzyme, the same one that statins inhibit. So you are on lipid medication if you're on TRT. But, I just want to be completely natural other than HRT. So I don't want any, mitochondrial toxic statins. And if I die, I'll just have a big heart attack and stroke and I'll be fine. And that is tempting Murphy's Law. And the specific part of that is you will never die of a heart attack and stroke, according to Murphy's Law. You will have plaque buildup and ischemic dementia, and you'll have ischemic dementia for 20 years. So if that can be prevented, then it is certainly something that you should consider controlling it, especially if you just have a genetic predisposition to where, it doesn't matter which type of FH you have or whatnot, or lipoprotein little a is arguably a lipid. Controlling that could be an important modifiable risk factor as well.
It's very true. Another thing to get tested, to add to the checklist. Mm-hmm. And we have, optimizing hormones, discussing HRT. This is also involved in the RECODE protocol. Insulin sensitizers, again, they did use some, well, I don't think they did, but I know there's a combination of alpha lipoic acid and omega-3s. One of the positive trials out there for omega-3s and looking at cognitive impairment and dementia. And then copper supplementation. Recently we saw a post. This was associated with increased muscle mass if you had low copper. Is that right?
Yeah, something like that. Again, that's a lot of correlation, but the primary target here is the huge percentage of the population that has had gastrointestinal surgery. And it doesn't matter. It could be bariatric surgery, could be a Billiroth. Yes, the highest risk is if you had a gastric bypass, like a Roux-en-Y or a biliopancreatic diversion, particularly high risk. And Diana and I have also posted about copper insufficiencies and just interesting things that we've noticed with a lot of individuals having lower normal serum copper, but perhaps normal intracellular copper. And then a lot of females that are on contraceptives, skewing that copper, perhaps when they found the reference range, that's what kind of pulled that normal looking copper higher than it actually is.
Yeah, it kind of reminds me of the alkaline phosphatase and maybe having a handful of pregnant patients in that reference population. Mm-hmm. And then inositol. So certain things can affect this, like lithium. Inositol is a known insulin sensitizer. Arguably, if you're insulin resistant, then any insulin sensitizer is going to be dementia preventive. Probably stay away from the sulfonylureas. But other than that, basically, whatever means you're using to improve insulin sensitivity is going to be a net positive.
Yeah. So if you're trying to prevent type 3 diabetes, things that prevent type 3 diabetes make a lot of sense. It's also in vogue to take, again, put on the Mickey Mouse hat for this one. It's in vogue to take lithium, not the lithium caprate, but the lithium orotate, the organic natural lithium. Which I guess it is kind of natural. It is just an element on the periodic table, but it is theoretically going to, or at least preclinically going to deplete inositol levels in the brain cells, probably even at low doses if you extrapolate from the rodent studies.
Mickey Mouse data.
Yep, from the Mickey Mouse data. But that being said, there's not a lot of downside to inositol supplementation. And when we test inositol, it's not unusual to see those with metabolic syndrome have low inositol, just like it's not unusual to see them have, high fasting insulin or low akkermansia.
Yeah, all these things basically, you sort of stack the associations together and try to get as many things in a low risk category or a category that's associated with better outcomes.
Yep.
And one of those things is omega-3s. So And basically, I think Framingham data is where this is sort of pulled from, looking at getting an omega-3 index of above 8%. The average person in the population, I think, hovers around 5%. I think Japan is actually closer to that 8%, which, again, there's obviously genetic differences there. It's not just diet that explains these health differences. But it was just interesting to me to look at the variation in the omega-3 trials and their effect on cognition. So actually, most trials showed a neutral or negative outcome, if I'm lumping those together. So it was only 7% of trials that showed a negative effect on cognition.
Yep.
And then 43% of trials showed a positive effect on cognition. But if you look at the range of the number of participants, look at the range of the total omega-3 dose, 79 milligrams, all the way up to 5,200 milligrams, duration 1 month to 74 months.
Yep.
It's hard to make much sense of something like this because there's not been consistent trials done, higher doses, longer periods of time, higher doses of DHA. Tom Dayspring, a lipidologist physician, he posted about DHA and its potential role in ApoE4 not too long ago. So there's a lot of interest in this area still. And this sort of contrasts with the numerous failed interventions where you've had all these trials are either considered to have no effect or even a negative effect, depending on the side effect profile.
Yeah. So like anything else, we like to check omega levels. And you don't even need to go to our website for that. You can just go to, I think, Amazon or the Omega Quant website, and you can just order your Omega Quant. You can do the blood spot test, send it back. And and that goes for anything. That goes for CoQ10, that goes for inositol, that goes for B12, that goes for vitamin D. Just stay objective. If it is deficient, then it is very likely to help you to correct that deficiency or insufficiency. And if you're going to splurge, like let's say you're in your 60s or 70s, or regardless, you might be having some mild cognitive impairment. Rather than splurging for testing on tick-borne illnesses that you have no risk factors for, but you're just screening that because everybody gets screened for that, rather than screening for various viral antibodies or even, as much as I love stool microbiome testing, even doing stool microbiome testing, as age progresses, you are more at risk of intracellular nutrient insufficiencies. So splurge for micronutrient testing.
Yeah, before you do a Lyme or mold or chelation protocol for heavy metals, that money for probably 99% of the population is better spent on a nutritious diet, maybe someone to plan out your micro and macronutrients, a dietitian, or even personal training, someone who's going to keep you accountable and push you, and you're going to see those improvements. That has a much better bang for your buck compared to some of this more fringe or niche scenarios that may have relevance in some cases, but for most people, you better start with the basics, get things dialed in there, and then you can always branch out.
That's what I'll tell my uncle who worked in a thermometer factory in Lyme, Connecticut. But yeah, hopefully that's a good summary. And we do have micronutrient testing posted on our website. It provides good context, partly just because you see these studies like high B12 levels are actually correlated with dementia. And you're like, well, is that because people who think they might have cognitive impairment take a B12 supplement? Because if you Google reversible dementia, B12 will pop up. Or is it because their B12 is actually on the lower end inside the cell? Maybe they have a higher homocysteine and B12 is just high in the serum and it's having a hard time getting into the cell. Zinc is also notorious for having this happen.
Yeah, I think those are good things for people to think about. And I guess now we can look at the dementia reversal graveyard. So we've got a ton of different things here. 3 different antibiotics that have been tested. So minocycline, doxycycline, rifampin, they didn't work. So most people who have dementia, it's not because of a Lyme, or you would have seen an effect with doxycycline, right?
Yeah, and it's probably gut endotoxin release, and they just needed to do a Xifaxan plus neomycin, and it would have worked.
Yeah, targeting amyloid beta. I guess it worked enough to get an FDA approval, but in my mind...
But not Medicare coverage.
Yeah, in my mind...
First one ever. FDA approved, not covered by the government.
Yeah, in my mind, it's still in the graveyard of potential interventions. Targeting tau, there's only one modality that has been tested in this manner. It was actually a methylene blue analog, which I thought was really interesting. But unfortunately, it did not have a effect. Next, we have raloxifene. This was pulling from some retrospective data, looking at women who were prescribed raloxifene and seeing a lower risk of dementia in postmenopause. And then when they did an intervention trial, they did not see a positive effect. And given sort of the question marks surrounding any SERM activity in the brain, we don't have these tissues fully mapped out. Raloxifene, for example, antagonist in the breast tissue, agonist in the bone tissue, question mark for the brain tissue. Again, I wouldn't bet on a SERM in the near term being the magic bullet.
Yeah, in hindsight, the women prescribed the raloxifene were probably lower risk of stroke and thus lower risk of dementia, because usually you're not going to prescribe a lot of SERMs to those at very high risk of a stroke.
Yeah.
Next is pioglitazone, the diabetes medication, and it was studied as a fatty liver medication as well. But yeah, I guess they just used the wrong PPAR agonist. They shouldn't have studied PPAR gamma or PPAR alpha.
Some cardarine is what you're thinking, right?
Some GW 501516. But in all seriousness, this is kind of a mitochondrial target. As people know, the PPAR system provides basically lipids as energy to mitochondria. So if you have too many lipids, you have that like metabolic overload. You're looking for exercise in a pill, and that's what PPAR agonists were studied for in general.
Yeah, then you have thalidomide, which did not have any effect, but was particularly not well tolerated.
Yep.
Then you have, again, talked about the antibiotics, estrogen. So this is actually considered failed, but also could be because of the limited duration of studies, different types of estrogen that are being used, where the estrogen is combined with a progestin, with no progestogen, or with progesterone. Again, if you would delve into each of these individually, there's a number of potential different confounding variables. And was this looked at for this specific, genotype? Was it looked at for this specific marker in the cerebrospinal fluid? You can slice and dice the data all you want, and that's something that has been sort of frustrating, is that the majority of these trials were just targeting amyloid beta, and despite reducing amyloid beta volumes, you're not seeing the outcome that you would hope for.
I'll be that guy, and I'll mention the huge confounders in the study of estrogen, not just in dementia, but in many disease conditions as well. And no, I'm not about to say CEE versus bioidentical. Surprisingly, here's your confounders. You replace with just estrogen or just estrogen plus progestin, you're suppressing your androgen production, especially in and around the time of menopause, where the ovary is still producing testosterone from the theca cell. Again, we could probably even put up this graph. If you give them estrogen replacement, their testosterone decreases quite a bit. So I'll call it partial castration if you do just estrogen. And obviously some people that have really high androgen pools, like, adrenal hyperplasia, that can be a good thing. But in the average individual, it is probably not. So that's one big confounder. The other big confounder is the average person is overweight or obese. So they're going to have really high amounts of aromatization. And those individuals tend to have higher DHEAs and estradiol levels after menopause. So replacing estrogen of a already slightly more normal estrogen is not as important. So if you're a better candidate for estrogen, then replace androgens if you need to, and ensure that, like let's say you're very metabolically healthy, you're at a very low body fat, and you go through menopause very early. That is an excellent candidate for estrogen. And it is not failed in a case like that.
Right. Yeah. This is just sort of in generalizations. There are scenarios, and it doesn't mean that you shouldn't ever use estrogen. Like we talked about, the KEEPS trial is probably the best we're going to get.
Yep.
And I think the big takeaway there is that, of the two forms that were used, the different protocols, there was not a decline in cognition. So whenever people are saying, well, you can't take HRT, you're going to get dementia, you have the KEEPS trial to look and say, hey, there wasn't any cognitive changes, and maybe a hint towards potential protective effect in E4 carriers. Then we have statins in general. They've tried simvastatin, atorvastatin, maybe a matter of too little, too late.
Yep.
NSAIDs, which are going to harm the kidneys, harm the stomach
that's
lining.
a head scratcher. Yep.
Increase blood pressure and sodium retention.
That one has truly failed.
Yeah. In a high risk of bleeding population, dementia who are falling.
Yeah, in hindsight, not great, but at least it's been studied so that we can put that behind us. Next is ginkgo biloba, which I like as an adjunct for those with ADHD, especially on ADHD stems, but failed as a dementia intervention.
Yeah. And then the last one we have is insenacline. I believe is how you say that. This is a nicotinic receptor partial agonist. So why not just use nicotine?
That's a pretty good question. Why not use cytosis? Why not use Tapex?
Yeah, it's also a nicotinic receptor agonist. Now, is that a partial or a complete agonist? The cytosine.
I'm not sure how strong of an agonist it is, but I believe it is just a normal like ligand agonist at the nicotinic receptor.
Yeah,
I don't believe it's an allosteric modulator.
A full cytosine podcast
Yeah.
looking at the differences in things like desensitization compared to traditional nicotine. But nicotine is an interesting one. I guess we sort of teased about this one earlier, saying we talk about nicotine, and now people can get their cropping or clipping tools ready to create a viral clip.
Yep.
But yeah, there is some data that supports nicotine in reducing the incidence of neurodegenerative disease. And this is even as an aside from, like, obviously people who are smoking are going to die of cancer and heart disease faster.
Yep.
So they do have a lower risk of dementia, a lower risk of Parkinson's. But it may have a neuroprotective effect when it's used low doses and very infrequently.
Yep. So don't take this out of context, or do. But I've mentioned, I love thinking about theoretical things. Like when I inevitably have prostate cancer, I'm going to take an enobosarm for it. Or when I theoretically have pre-Alzheimer's, and I'm going to take my friend Dr. Scott Scher's Troscriptions. Just it comes in 1 milligram nicotine in a troche, and you can quarter them. And you could take 0.25 milligram nicotine. And for the audience that uses nicotine, they're laughing at me for my completely sub-efficacious dose where I feel nothing.
Are 12 milligrams.
But I'm going to take that 12 times a day, basically whenever I think about it. So maybe more or maybe less than 12 times a day.
The lowest dose nicotine on the market, I believe. Yeah,
very, very low dose, and that's Troscription. So again, I don't take that now. I do occasionally take a Tapex, which is Crave, CRAVV in Canada. And we'll do a full podcast on that because that's just going to be fun to talk about. We'll talk about Chantix and all other sorts of things at that time.
Yeah. And the caveat here is that using low doses of nicotine infrequently, those two things can be very difficult for people. It can be a slippery slope. If someone has a 10th of an addictive personality, they're probably going to end up using this more than they had originally intended to.
Yep.
So this isn't something that I recommend willy-nilly to every person who wants cognitive enhancement or dementia prevention. Again, you're going to go back to those foundational things like managing risk factors, blood pressure, diet, exercise, insulin sensitivity, all these sorts of things before you're thinking about what do I take.
Yeah. It's just fun to discuss what you take.
It is.
In fact, I think you were theorizing, you were like, I'm going to be smarter about this. I'm just going to take an ultra low dose nicotine patch.
Yeah. If I was going to use nicotine maybe once a week, I think that would be a risk neutral dose. Maybe I have a little bit of vasoconstriction. But if I just put a ultra low dose, whatever the lowest dose patch is on for, let's say 30 minutes, an hour, I'm still going to get some nicotine in my system. I'm probably not going to feel it. And people are like, well, you're going to be wasting it then. Don't you want to use it for productivity? Where I'm at right now, I feel like my productivity is good enough with a cup of coffee once in a while.
Yep.
So for myself, it would just be purely neuroprotective, potentially.
Yeah.
It's not something that I'm abandoning all of the risk factors and just betting on. But that's probably the method I would use it. And then I could reimburse myself from my HSA.
Yeah, that is pretty smart. Probably smarter than taking some blue cannatine. But on that note, a lot of things that you take for cognitive enhancement should not necessarily be felt. Whether that enhancement is having anorexic feelings, not being hungry. GLP-1, you really shouldn't feel strong. Now, you shouldn't feel hungry, but you shouldn't also feel not hungry. Same thing with nicotine. You shouldn't feel hyper buzzed, but you also shouldn't feel sluggish. Same thing with ADHD meds. If you have ADHD, even if you're a child, I would argue you shouldn't feel, focused out of your mind like you're in a different world on a huge dose of methylphenidate or an amphetamine salt.
Sounds like finding the Goldilocks zone.
Yep. But yeah, I think that pretty much sums up our review of failed interventions. Hopefully people have gotten a lot of tools from this. I guess we forgot to give our discount code for all the different supplement companies that we have, because that's what we're really trying to sell here, right? Getting all the YouTube and Spotify bucks.
Yeah, I don't think we specifically put supplement links in the description. If you see someone that has 42 Amazon links to different products in their description, then you sort of know where their values lie. Not always, but again, directionally, I would say more than half of those people are probably more interested in just the financial gain.
Yeah, this topic, like most of the topics we talk about, are near and dear to our hearts. We both have lots of family members or very close friends that not only have neurodegenerative disease of some sort, have suffered from many health conditions. So that's really the impetus behind why we do this. So hopefully you've kind of like gotten through our dry, sarcastic, sassy humor and our like slight, I don't want to say anger, but anger with the conventional medical system and its lack of preventive care, and then also the alternative medical system and its Mickey Mouse data. But hopefully this has given you some tools to develop a balanced approach to preventing dementia.
Yeah, thank you so much for your time. Thank you for watching. May God bless you with health and happiness.